Okay, well, hello, everyone. The title of my presentation for today is Harms of a Single Story, Moving Beyond Medication-Centered Treatment. Very briefly, in terms of introduction for folks who don't already know me, I am an associate professor in the School of Social Work at the University of Pittsburgh, mental health services researcher. Over the years, I have worked in a variety of roles, including state government, so mental health services, sort of policy, technical assistance and oversight work. I have worked in the public mental health sector in a variety of roles, as well as co-led my own peer and family-run organizations providing direct supports to family and individuals experiencing what we label psychosis. And then as a researcher and faculty member, also teach at this point social work students. So a lot of different kind of experiences of different facets of the system in that way. I have personal experience of schizophrenia as well as family experience, essentially lifelong kind of experiential immersion in the public mental health system from that perspective. And I am very passionate about this work and very kind of committed to thinking about what it really means to change things, given what I would say overall are unconscionably terrible outcomes in this country for people with long-term significant psychiatric disabilities. So with that, I will dive in. Again, this is a particular kind of slice of things, and for the purposes of this conference, was asked to speak on this kind of topic of medication-centered treatment and what the sort of alternative would be. So a brief overview of my argument. So I am, and I want to be very adamant about it, and will repeat it in a couple of places, that I do not in any way see antipsychotics themselves as the problem or even a problem, but rather the way in which we as a society, we as systems, have come to center them, right? So the extent to which they now structure and dominate our conceptualization of psychosis and how we respond to it, that's the problem. It's not antipsychotics, that's themselves. Antipsychotics help many people, have middling effects on many people, cause harm to others, but certainly in that mix is a lot of benefit. And many people are very kind of grateful, right, that antipsychotics exist. So this is not an anti-medication argument I'm making. This is a reflection on, I think, the considerable harms of centering medications, often to the exclusion of anything else. And I refer to this as a single story. It's a single story that we tell about antipsychotics, and that extends into the way that we conceptualize psychosis itself and believe that we should be responding. The far-reaching harms that I am concerned with are that this recourse to antipsychotics and antipsychotic-centered treatment reinforces reductionism, right? Reductionism meaning an oversimplification of what we're dealing with, of how it impacts people, of the role it plays in identity and identity formation, et cetera. This takes the form of believing that psychosis is fundamentally a disease, disorder, and or psychopathology, right? This set of terms, that's sort of all it is. And once we have sort of oversimplified what we're talking about to this disease entity, it tends to follow that we are intervening in narrowly biological ways, and that social, structural, rehabilitative interventions end up marginalized, decentered, right? They're adjunctive, they're on the periphery, they are not the central thing that matters. These beliefs about sort of what psychosis is and the centrality, right, of medications contributes to practices that really strip psychosis of meaning to the individual. Rare, not not unheard of, right? But actually rare to meet somebody with long-term psychosis that hasn't just been resolved, who doesn't invest considerable meaning in their ongoing experiences, whether that's negative, positive, polyvalent, right? These are complex, rich, deep experiences, and they come to matter to people and to carry meanings in a whole host of different ways to the individual. So I think that's more the norm than not, right? They fuel what I would call carceral interventions, right? So I'll talk, kind of more about the logic linking antipsychotic centrism to involuntary intervention farther along, but involuntary treatment, involuntary injections, et cetera. And then displacing social and structural interventions, social and structural analysis. What are really the problems that we face as systems, as society? Most often they are, in fact, structural in nature. Those are the true sources of inequality, discrimination, oppression, and the deepest ways they manifest. And when we think we just need to give an individual a pill, it removes our gaze from these much deeper, much bigger problems. So that's the argument in a nutshell. I want to next give you all some examples of what I mean by medication-centered thinking conceptualization. I semi-randomly, not quite randomly, I looked at recent systematic reviews. This one is on clinical practice guidelines for antipsychotic pharmacotherapy from just 2 years ago. Chris Correll, who is a very, very established senior central kind of figure in U.S. psychiatry. And this is the first paragraph of this systematic review of clinical practice guidelines. And I think this conceptualization of antipsychotics is absolutely standard. This is the mainstream view, right? This is what we see characterizing how medical students, residents, and psychiatric fellows are trained in the United States, but also social work, clinical psychology, nursing, et cetera. So I'll just read this. Schizophrenia is an often debilitating, chronic, and relapsing mental disorder with complex symptomatology that manifests as a combination of positive, negative, and/or cognitive features. Standard management of schizophrenia includes the use of antipsychotic medications to help control acute psychotic episodes and prevent relapses, whereas maintenance therapy is used in the long term after patients have been stabilized. And just note the language here, right? This is for probably most of you in the audience, you're used to it, but depending on your positionality, you might not have as much sort of just repeat exposure to this kind of language and thinking. Two main classes of drugs, first and second generation antipsychotics, and this gets abbreviated FGA and SGA, are used to treat schizophrenia. SGAs are favored due to the lower rates of adverse effects, such as extrapyramidal effects, tardive dyskinesia, and relapse. However, pharmacologic treatment for schizophrenia is complicated. And here, right, is always the link to behavior because non-adherence is prevalent and is a major risk factor for relapse and poor overall outcomes. The use of long-acting injectable versions of antipsychotics aims to limit non-adherence related relapses and poor outcomes. And I think in this one paragraph, we see a distillation of where sort of the mainstream of psychiatric practice is at. A second example, right, kind of turning away from sort of academic publications and stuff that trainees would be reading to the psychoeducational materials designed to be literally printed and handed out to clients and families. And this comes from the NIMH RAISE Navigate study, which is now a model implemented across the US for early intervention and psychosis programming. And again, I'm making the point here, this is contemporary, widely used, and widely considered to be actually a holistic, recovery-oriented intervention model. And I just want to read you some of the language and suggest that you just think about how medications are presented and kind of implicitly positioned, sometimes explicitly, and the overall kind of thinking, right? And the relative narrowness of it. So just the facts. This is part of the Relatives Guide to Supporting Recovery from Psychosis. So first sentence, loving a family member with a serious psychiatric illness can be challenging. Just think about that framing. And then fortunately, a relapse is less likely to occur if a relative encourages a person who has had a psychotic episode to bullet number 1, take medication as prescribed, right? Medication centrism right there. For both patients and families in the Navigate model, what causes psychosis? So this is basically gets right to stress diathesis. So a number of theories have been suggested, but there's still much research to be done. So some acknowledgement, right, of how much we don't know, but then there is some indication that psychosis is caused by a combination of biological factors which create a vulnerability to experiencing psychotic symptoms during adolescence or early adult life. These symptoms often emerge in response to stress, drug abuse, or social changes in such vulnerable individuals. Some factors may be more or less important in one person than in another. The combination of biological vulnerability and stress, which can lead to psychosis, is called the stress vulnerability model, or some of you would know as the stress diathesis model. We then have, like, in a box, right? Psychosis is nobody's fault. People do not cause it, although in very, very real ways, that is not true, in the sense that we know huge mountains of evidence, right, that there are sociostructural causes of psychosis. Those include poverty, those include childhood adversity and trauma. These are very much conditions that are created by humans, by society, right? This does not rise in a sort of a social vacuum. And then moving on to just the facts, medications for psychosis. So why is medication recommended as part of the treatment for psychosis? Taking medication regularly can reduce the severity of symptoms and prevent or minimize relapses. In the Just the Facts psychosis handout, you learned about the stress vulnerability model. This model is based on evidence that both biological vulnerability and stress contribute to the symptoms of mental disorder. And then here, key medications reduce biological vulnerability by helping to correct the chemical imbalance in the brain, which is actually a great oversimplification for anyone who is familiar with concerns that have been put forward by many, many scientists. In fact, so much so that many psychiatrists will completely and utterly disavow that they have ever told patients, right, that antipsychotics correct chemical imbalances, since that is such an oversimplification based on the current state of science. Nevertheless, this is the kind of messaging that we continue in materials like this to impart to clients and families. And of course, the providers who are being trained in the model. So again, medication centrism, here's what I mean, right? This is the form it takes. This is the type of messaging and communication that centers medications, links them to biological causality, precisely what I'm talking about. How does this play out in and through inpatient hospitalization, which nearly everybody in the United States who experiences multi-episode psychosis is going to be hospitalized. And in most cases, at some point, involuntarily hospitalized, but virtually everyone ends up inpatient at some point. So again, as those of you who interact, work with or within these systems almost certainly already know, the primary intervention in acute and inpatient settings in the US is pharmacotherapy, is medications. In many settings, that is the only intervention available. This also applies to crisis stabilization facilities. I know of many where literally, quite literally, there is nothing else. There is no service available other than rooms you can sleep in, a gathering room, food, and then nurses' stations that dole out medications. That is crisis stabilization. In many states, Medication changes or switches have become the primary, again, if not the only billing justification for inpatient hospitalization for, say, extending or justifying a stay, unless you're meeting some kind of imminent harm criteria. Billing for psychotherapy is often outright impossible. Group interventions we see more often in inpatient settings in the US, but in some contexts, even group interventions of a more sophisticated kind are really difficult to fund and to rationalize within kind of hospital financing systems. Stays in the United States have become extremely short, often only a few days. This kind of reinforces this operative conceptualization, way that we do inpatient psychiatry in the US as really just an occasion for short-term medication stabilization. We don't have time to engage in therapeutic or psychosocial work in a deeper way for the most part. Patients are very often discharged on different multiple and or higher dose medications than they came in on, again, in part because psychiatrists within inpatient settings are often forced to switch meds, increase meds in order to justify the patient's time in the facility. So we have something that in a sense could be and functionally is central to the experiences of an awful lot of people, and it entirely revolves around medications. And I think there's very, very few places that one would call sort of inpatient hospitals in the US where you would go where this would not be true. Sometimes there are certainly sort of more Cadillac private facilities that actually do provide intensive psychotherapy. That's very unusual, and there's very few people in this country who have the means to pay for that and the access to it. So some of the operative logics here, and then consequences. So once we have decided that antipsychotics are the primary, the singular, single story, primary, most effective intervention, of course, the whole field becomes fixated on that. The more we fixate on it, we create feedback loops. It's self-reinforcing. If that is how we view crisis stabilization and inpatient, it's all about medications. It is almost entirely about medications. That just further reinforces this idea that the central thing we're doing for people revolves around medications. Then what becomes the big barrier, as we saw in that kind of systematic review from Chris Carell et al., is non-adherence, right? So non-adherence then is the problem. How that gets constructed varies somewhat, right? So people lack insight. They lack the ability to appreciate that they need antipsychotics. That's sort of one line of thinking. There are, I think, often less explicitly spoken, certainly in the academic literature, but often thought is more blame, right? Is people are not cooperating, people are not motivated, and sort of motivation deployed in a moralizing sense. As a consequence, as we saw, again, just going back to that one paragraph summary from Carell et al., adherence-focused interventions and or really long-acting injectables become a major priority. They're a major priority. Now you cannot go to a psychiatry conference that sort of deals with what we label serious mental illness without hearing numerous presentations on long-acting injectables, because this is a way of ensuring, right, that the substance is indeed injected into the individual. And again, when our view of intervention revolves around that, we feel like that is a tremendous policy success, right? The more that we can kind of disseminate LAIs. Again, this all sort of reinforces and is reinforced by a belief that neurobiology is the problem, and therefore intervention at the level of neurobiology is the real solution. Other approaches are either temporary, right, or they're Band-Aids. And even from a scientific perspective, they are Band-Aids until we discover the cure. Numerous directors of NIMH have repeated precisely and exactly this. I could have just put a quote here, right? In fact, Tom Insel, after the President's New Freedom Commission report was released, Actually, his response to the President's New Freedom Report was to say this recovery-oriented stuff, okay, like whatever, right? It's temporary, it's superficial, it might even distract us from the cure, which is the real thing we need to be oriented towards. Hence, we need neurobiological research to be prioritized, not any of this sort of clinical and services stuff. So this is really a problem, and different consequences. This is not meant to be exhaustive. I'm just kind of trying to present a few key ones. So in many fields, since we have had this turn, right, the sort of turn from old school, long stay, state hospital, still very carceral, very problematic, needless to say, but a very different type of treatment environment. Then we kind of turn to medications, short-term hospitalization, and actually relatively kind of minimal services in the community. But that turn, we see that fields like nursing, which once upon a time, nurses got pretty significant training, for example, in psychotherapy, as well as other kinds of psychosocial interventions, predominant focus on medication management. Of course, that is also true of psychiatry. Psychiatry overseeing medication management, and often psychiatrists are able to do nothing else, in part accounting for the really low job satisfaction of many psychiatrists who are not in private practice. Go into private practice, you can kind of charge people to do psychotherapy, but you can't bill for it, certainly on the Medicaid side. But appropriately then, psychiatry is at the top because we are really dealing with a medical, neurobiological issue. The primary and most important intervention is medications. Hence, of course, it makes sense to have medical directors, folks with an MD, mostly psychiatrists, overseeing things in really, really key roles across all kinds of systems and agency, VA kind of hierarchies. You have SMI training, right? Training, or we could just say psychosis specifically, has all but washed out. And that is equally true in social work, in counseling, in clinical psych. So because everything is so constructed around medications, right? It is not seen as a priority to train folks in psychosocial, psychotherapeutic interventions for psychosis. In fact, what most people are going to get in these kinds of programs is a DSM class in which they memorize DSM criteria and then just kind of learn about the medications, right, that might be prescribed to people with schizophrenia. And that's what they walk out of a social work or a counseling program with. And sadly, the same is most often true of clinical psych, unless somebody ends up in a particularly kind of good internship or practicum of some kind. Funding, as I was saying, predominantly focuses on basic and translational research as well as drug trials. The budget for the Division of Services and Intervention Research at NIMH is only 10%. All of intervention and services, right? All the rest of the money goes to other areas of research with a heavy concentration on basic and translational neuroscience and genetics. So this, again, sort of the directionality here is complex because really what we've created is just feedback loop, right? The more we concentrate on medications, the more we center biological causality, the more we do things that align with that framework, which then reinforce our own thinking and on and on and on. And we end up with the kind of system we have, which I do not have time in this presentation to go through sort of a catalog of where outcomes really at. They are terrible. Where is engagement at? It's terrible. Disengagement from the system is more the norm than not. And I will say one powerful new kind of contribution to our understanding of levels of disengagement engagement is the new-ish. Initial results were released last fall from the SAMHSA-funded prevalence, SMI prevalence study, in which we see that well over half of individuals with an SMI diagnosis have not received any form of treatment in the prior year, right? So we have a massive, massive problem of people who have left the system, who distrust the system, who don't want to engage for a variety of reasons. We have abysmally bad outcomes. Research looking at decade-on-decade trends finds no improvement in outcomes in this country or sadly anywhere else in the world when it comes to multi-episode psychosis. So the system we have is not working. All right. So what do we do? And again, this is a short presentation. This is not meant to be comprehensive or exhaustive. I think I just picked a handful of things I thought it would be valuable to talk about today. So first, restructuring inpatient practice and policy. Financing, we cannot do this without thinking about financing, right? So financing has shaped a lot of things, including allowable length of stays, what services are provided and what are not, what is required to bill, right? Medical necessity, and what the rates are and how those rates vary across different kinds of services. So we need to just, I think, kind of stop and realize that as hard as policy change always is, we're not going to fundamentally change what the inpatient experience is like for people without dealing with how they're financed. Fundamental rethinking of environments we have normalized across the US. So it is standard for patients and inpatient to have no access to green space, to fresh air at all. No access to exercise equipment, or in some cases, it is a privilege that people could access at most a few times a week, only if there is sufficient staffing to allow it. And throughout COVID and still in sort of the COVID aftermath, where we see significant staffing shortages in the US, often because the staffing isn't there to accompany and oversee people, right? There might be an exercise room and nobody can actually use it. And that's a real problem, right? When we are sort of the messages that we are sending to people about what value, what matters and what is valued. It is standard for people to have no access to cell phones or computers or books or art supplies or anything like that, right? But cell phones in particular, I think, are a big one. And I do know of exceptions, and they are very rare, one being the San Francisco VA, psychiatric inpatient hospital, which fully allows cell phones, has charging stations, has very much figured out ways to make that work and to still kind of ensure confidentiality, privacy, and safety. So it's not that it can't be done, it's that we don't even think it matters enough to do it, which tends to create wards, especially when you have psychosis-specific wards in larger psych hospitals that are pretty horrific places, absolutely, utterly barren of anything that you can do, that you can occupy yourself with. Maybe there is, one television behind unbreakable glass, way up atop a wall, and, staff are just playing soap operas or whatever on it. The use of what euphemistically get referred to as sedative PRNs in acute and inpatient settings, or more colloquially, booty juice in one manifestation, right? In terms of injections. And then seclusion and restraints are normalized in these environments. Many people are trained there. That includes social workers, right? Number of the social work students in our MSW programs, for example, get field or practica experiences on adult inpatient wards. So that's what they're seeing. They're seeing people in an environment in which there is very little to sort of stimulate yourself or engage in, right? So there's just absolute boredom, which we know in many kinds of settings is going to kind of fuel violence, frustration, a lot of sort of negative things, right? So this shapes the environment in powerful ways, not just for those patients who are directly subject to these interventions, but everybody who is witnessing it, everybody who is part of that environment, everybody who is being acculturated to what mental health intervention is, to what psychosis is in this way. And we need to really, really think about that. Think about what we're doing, how we're influencing people, and the kind of culture that we have allowed to kind of take hold in patient environments in the US. And we need to actually, I think, kind of bring in a goal of healing and support, of creating healing environments rather than containment and medication-based stabilization. And then we need to recognize these relationships, right? That it's not an accident that these things kind of go together, hang together in the way that they do. That if we are conceptualizing psychosis in this very, very narrow, biomedically reductionistic way, if we are conceptualizing intervention in this very reductionistic way, a lot of everything else we see naturally follows from that, and including very much in the way that that inpatient environments are structured. Go to the average nurse's station, what you see is people's like pills lined up, literally medications are everywhere. And you might see like a whiteboard chart, right, that just lists out the medications that everybody is getting so that the nurse on staff knows what to take to who. Okay, second, rethinking the central place of antipsychotics in family and client psychoeducation. I think I wanted to go here in part because I showed you those materials from Ray's Navigate, right? And again, I want to just reiterate and repeat that antipsychotics can be a very valuable tool, are a very valuable tool, one tool among others, and they're going to be valued by some people and not valued by others. We know that actually more people than not refuse to take antipsychotics who have long-term psychosis, right? So valued by some, not valued by others, effective for some, and we know this from effectiveness data, right? Not effective for others. And then sort of in between, where it's kind of a toss-up of whether the sort of risks and side effects do or don't outweigh moderate or mild beneficial effects. And we need to kind of think about how we can message that, how we can message a real kind of openness to people deploying a toolbox of their choosing, not one that is in fact centered around medications. And I think, this would lead to, if we embrace this kind of thinking, we would then want to overhaul I just showed you one example, right? But you can just kind of Google psychosis, Google antipsychotics, and find site after site after site with the same kind of language, right? So thinking about patient-facing websites, brochures and pamphlets, briefs, and then kind of full-on psychoeducational interventions for anyone who is familiar with multifamily psychoeducation. The standard psychoed materials are very much along the lines of what we just saw earlier in the Navigate set, Ray's Navigate itself, et cetera, et cetera. So where we literally have studied interventions where this kind of thinking is baked in and designed to be distributed, disseminated, and imparted in a variety of ways to patients and families. 3, and I think because this just doesn't get talked about enough, I wanted to include it, sort of defetishizing, deromanticizing shared decision-making and advanced directives. So I am pretty cynical about shared decision-making. When the dynamic between prescribers and patients, and not just prescribers, honestly, but in most cases, the whole treating team, is fundamentally known to be one party wants one thing, and that is medication adherence, and the other potentially doesn't. In many cases of people who end up disengaging, that's exactly what they don't want. But they are well aware of the beliefs of the first. Sort of paying lip service to shared decision-making doesn't take away the fact that I have yet to meet a patient with long-term psychosis who is not acutely aware that their prescribers and indeed their whole treating team, in fact, just wants them to be taking their antipsychotics. So there is just a really, really fundamental kind of power knowledge hierarchy there and problematic type of relational dynamic that in no way does this kind of euphemistic language of shared decision-making overcome. I don't think it gets us very much. It's not a bad thing. It might make a modest contribution, but it is not revolutionary. It is not transformative. And again, the more we get caught up in thinking the way that we can empower people in the context of medication decision-making is shared decision-making, the more we're just kind of going farther and farther down a rabbit hole that is not really truly very, very transformative, that changes very little and that doesn't fundamentally change the underlying dynamic that is the actual problem, in a sense that you have fundamentally conflicting perspectives. Advanced directives, I think similarly, really make only a modest contribution to this set of issues. It does allow patients or clients, right, to articulate their preferences. And there's, evidence showing that people feel better, more optimistic after they've completed an advanced directive. The evidence is pretty grim, weak on enforcement of advanced directives when and if people actually get hospitalized. And there are limited options or alternatives, right? So in fact, advanced directives do not somehow magically capacitate a different treatment landscape. They at best allow an individual to exert some kind of communicative preferences, right, around navigation of very, very broken systems. And they are easily overridden legally. In practice, and especially in the context of psychiatry. There are actually broader problems with all forms of advanced directives, but they are even easier, I think, to override in practice on the psychiatry or mental health side. So again, they're not bad things, shared decision-making and advanced directives, but the problem is that we tell ourselves that this is sort of a much more transformative, empowering, liberatory way forward or set of interventions than it really is, and that prevents us from focusing on much more deeply needed areas of change. And then kind of fourth, right? And again, this is not meant to be comprehensive. I'm actually trying to sort of talk about some things here in these suggestions that I think get talked about less. That's really why I'm focusing on them. So we tend to blame psychiatry rather than the fact that there has, in fact, and indeed been a huge societal shift in the embrace of psychopharmacology across the board. And that includes people with no diagnosis at all embracing what we could call psychopharmacological agents for some form of, mental change, whether that's performance enhancement, right? Whether that's taking stimulants just to stay up later, study harder. So this is rampant among medical students, among law students, et cetera, et cetera. So it is not just psychiatrists. Society has taken this up, and along with it, attendant conceptualizations of subjectivity, selfhood, disorder, et cetera, et cetera. And, if we think over the past 100 years, this has been a really dramatic shift, really, really dramatic. Some anthropologists and critical sociologists refer to this as pharmaceutical selfhood, this new sort of reality of pharmaceutical selfhood. And this embrace of the pharmacological impacts the clients we're talking about more narrowly, right, in a variety of ways that do not directly have to do with active psychiatric policy, communication, messaging, or practicing psychiatrists, right? But rather through social institutions, through networks, social media, right? Family, friends, employers. We're all talking about, on some level, pharmacological substances pretty regularly and viewing the world through a lens that has become very inflected by that kind of thinking. So this is something that we have to take stock of, not just blaming psychiatry and blaming psychiatrists, but really thinking about this is a societal thing at this point in time. What does it even mean to engage in critical dialogues around this collectively at a societal level again, and not in a way that just kind of plays into, I think, an equally harmful and very simplistic kind of anti-medication, anti-science kind of trend, which we also see, and which is also responsible for some kind of really extreme public health problems that we have faced, for instance, in the context of the anti-vax movement. So I think there's a lot here that we need to be engaging with and not thinking it's sort of unrelated to the narrower set of problems that one is dealing with in trying to reform or revolutionize psychosis treatment and outcomes in this country. Okay, and because this is a short publication or a short presentation, I end there. Thank you all for listening. Again, not meant to be comprehensive, but meant to raise some provocative points, I think, to get us all thinking and to say some stuff that I think I see less talked about, less reflected on at conferences and in a variety of kind of outlets and venues.